I'd like to thank Dr. Beiske and Dr. Litwin for being with us and for their presentations for this program. We're going to do some questions and answers now, and then we'll have a few cases that we'll talk about and see how they would go about managing some of these. The first question that I have is for you, Demetrius, and it's regarding the use of diagnostic laparoscopy in the setting of the traumatic acute abdomen. You nicely covered the issue of non-traumatic acute abdomen, but is there a role in that setting?
Well, I think there is. I think with the one caveat that pneumoperitoneum will raise intracranial pressure, and what often happens is that the patient has an associated head injury or a suspected associated head injury, and I think it's probably relatively contraindicated in that setting, although the true risk, I think, is uncertain and unclear. That having been said, in those patients that don't have a raised intracranial pressure and head injury, or for those patients that don't have the potential for head injury, who have uncertain findings in the abdomen, I think the laparoscope can help sort that out. I do think some of the concerns that were previously mentioned in trauma, namely the inability to run the small bowel and so on and so forth, we can do very, very well. The one area where, whether it's the acute abdomen, whether it's a traumatic situation that we can't see well in laparoscopy, is the retroperitoneum. And therefore, it's imperative that we have a CT scan that visualizes the retroperitoneum, particularly in the trauma situation. You've got to see the pancreas, you've got to see the kidneys, you've got to see the retroperitoneum in the pelvis. I mean, we don't see that. We can't see it well laparoscopically, and we can't evaluate it well. But beyond that, we have used in selected cases laparoscopy to define the extent of intra-abdominal injury. We certainly use it in those situations where we think there's diaphragmatic rupture as the diagnostic treatment of choice. And we have used it on occasion for those patients that we feel have had traumatic splenic injury diagnosed and that are failing conservative management. We've actually removed a few acute spleens. Of course, those patients are not actively bleeding at significant levels to be hypotensive at that time.
What about, do you think there's a risk with a liver laceration of getting an air embolus? Certainly that would be a theoretical risk. Do you think that's a real risk?
Probably not. I think it's very hard to get air embolism from a traumatic injury to the liver because of the collapsibility of the liver. It's very, these vessels don't stay open and suck air through them. If you have a major caval injury, that patient's going to be bleeding at such an extent that you don't have the luxury of laparoscopy.
Okay. There were a couple of papers about laparoscopic repair of small bowel injuries, of blunt small bowel ruptures that were effective, and they're fairly big series, 27 in one and over 100 in another. So that would be another reasonable application.
So if you're always going to do a CT scan first, or almost always going to do a CT first in the trauma setting for the reasons that you've indicated, and you're not going to use laparoscopy in the unstable patient, hypotension, that sort of thing. So it's that stable patient maybe has a little bit of fluid, or you're watching the patient and they're not getting better and you think something may be going on. That would be
Correct.
A situation in which...
Uncertain findings, evolution of an intra-abdominal process. They come in not very tender and they become more progressively tender over time. The CT scan just showed a little bit of fluid and you're uncertain as to what's going on.
Let's go back to the setting of acute non-traumatic abdominal pain. And let's say you're doing a laparoscopy for a patient with acute pain. You suspect maybe they've got appendicitis, and you get in there laparoscopically and you don't see any pathology and the appendix looks normal. What are the steps that you go through?
Well, typically obviously I look at the appendix. Now, I must say that occasionally I've been fooled. I've looked at what appeared to me to be a macroscopically normal appendix. I've taken it out, I've sent it to the pathologist, and he's actually said there's ulceration of the mucosa, and in fact a process, and in fact appendicitis is present. So I think you can be fooled. So I do take out the appendix in the vast majority of cases. And then I look around the abdomen. I typically look around first because I want to treat whatever the primary pathology is first. And So I would do what we classically were taught to do. I'd run the small bowel looking for a Meckel's. The difference between exploring through a right lower quadrant incision and laparoscopy is that through a right lower quadrant incision, it's hard to run the entire small bowel, but I can easily run the entire small bowel laparoscopically, particularly from the port positioning that I had demonstrated for appendectomy. It's very easy to start distally and work your way up to the ligament detritus. And so I look at the entire small bowel. In women, I look at the adnexa, the uterus, ovaries, where often there's pathology. And if that's all normal, then I begin to look at, further away. I want to look at the gallbladder. Occasionally a process can track down the paracolic gutter and fool you. I look at the anterior wall of the stomach. I will not probably open the lesser sac in that sort of scenario. Presumably I have a normal amylase and lipase. Presumably, if you look at the foramen of Winslow, there's no purulence. The stomach anterior looks fine. I probably won't look at the posterior wall of the stomach. I look around for other things, not just purulence, but blood or something else that might be going on. And if that exploration is negative, then in fact I do the appendectomy and the operation then is over.
I've also had the experience of the appendix really looks fairly normal. You take it out, you don't find any other pathology, the pain's gone. And the other reason for removing it in that setting is that it eliminates it as a future source of diagnostic confusion if the patient comes back with recurrent pain down the road.
Yeah, I also would take out the appendix. And let me just add that I think in women of childbearing years, and in this era that's anywhere from 8 to 65, I guess, I'm often glad to use a uterine tenaculum so that you can get a really good look at the adnexa, and if you don't think about it or plan it ahead of time, it's sort of hard to get later on.
Yep, good point. So Joe, you're in there through a small right lower quadrant incision and the appendix looks normal. What do you do? You've had a CT scan, it doesn't really show much else.
Well, I'll tell you one of my favorite stories about that, which is that I used to let the chief residents pick their approach in the middle of the night, whether they wanted to do it laparoscopically or open, and we did that exact situation, small 2-centimeter incision and normal appendix, and when we stuck our fingers in, we could actually feel something abnormal. So we put a scope in through the little incision and found an inflamed gallbladder. So we did a laparoscopic cholecystectomy after starting with an open appendectomy.
So it's open appendectomy converted to laparoscopic cholecystectomy.
Exactly. I think a first case report. But if you start off with a small incision, I think it can be very hard. You do what we were taught to do as residents, which is to try to run the bowel. You would almost certainly end up extending the incision. Having had that experience, it might be smart to put a scope in. There's no reason not to back up and start over again at that point.
That's a good idea. You can usually see the right ovary, but it's really hard to get to the left side through a small little incision. Let's turn to the issue of chronic abdominal pain. That's a really challenging problem. I think we all probably cringe a little bit when these patients show up in our office and they've usually had extensive workup as you've outlined and really have come up with nothing, and someone has told them that they've got adhesions. That's the cause for their pain. There was an interesting study from the Netherlands where they did a prospective randomized trial of patients who underwent diagnostic laparoscopy for chronic pain, and they excluded a few patients because there were 3 who had stricturing adhesions and there were a few who had no adhesions, and they took the remaining 100 who had adhesions and they randomized them to an adhesiolysis done laparoscopically or no adhesiolysis, and they blinded the patients and then followed them to see what their pain response would be. And the incidence of freedom from pain at 12 months post-op was the same in both of the groups. So the question is, should we be doing adhesiolysis in patients that have chronic pain? Certainly a diagnostic laparoscopy is not unreasonable in some of these patients for the reasons that you mentioned, but if you get in there and you only find adhesions, should you take care of them?
Well, you've asked a really good question.
And a part of the reason why I think that's important is because you can sometimes get into trouble doing the adhesiolysis, and you get a nick in the bowel, and then you've created a new problem for the patient.
Many times these patients are sent to me because I'm a laparoscopist, and they think that we can do this fairly innocuously. But the reality is, it's a general anesthetic. Typically, these patients will have a lot of adhesions. Even if they don't, there's always that risk that you'll get a serosal tear or something that might leak later, or you might inadvertently cause some degree of electrocautery injury to the bowel or heat injury if you're using the harmonic scalpel during the lysis of adhesions, and this patient would then have a very bad outcome potentially. So this is not innocuous, and I think one has to bear that in mind, firstly, from the get-go. The second thing is that a lot of times one has to be cognizant of what it is that one's really trying to achieve, and that's why it's absolutely imperative to understand what the pain syndrome is, where exactly they have the pain. Because if you mark a spot that's very reliable in the right lower quadrant and you get in there and the right lower quadrant looks relatively spared, or let's say there are adhesions, but there are adhesions in other places, I mean, does one go after those other adhesions? Why would one go after adhesions in the left upper quadrant if the pain is in the right lower quadrant, for example? And I typically would not go after those adhesions. I would try and focus on where the pain syndrome is located. I think what that study speaks to is how reliable or credible the patients are and what the outcome will be depending on that. And I think you have to be very circumspect in terms of your patient selection. I mean, the patient has to be very reliable, very credible. They have to have the same story time and time again. That same story needs to have been told to the other physicians that they've seen up until that point in time. And then I think on some occasions you can justify that approach. But on many occasions I don't think you can justify the approach because I think you'll find that, quite frankly, you won't find much in the abdomen. I think if you are vigilant, you will find some people with strictures. You will find the occasional person that has an adhesion that if you lyse, they'll get better. And you might find people with, you know, stranding and tethering of a chronic appendicitis or something of that nature. But I do think that if, depending on how liberal you are, you'll have a very high rate of failure ultimately in relieving these patients' pain problems.
Do you ever use ultrasound to map the adhesions to see if there's a correlation between abdominal wall adhesions and pain? I haven't tried it. I read about it all the time.
Right, no. And I haven't used conscious sedation either in terms of pain mapping. I've just not done any of that. I must say, I try not to do a lot of this. I really like to be as certain as I can. I want to make sure that these patients have been completely worked up. I want that entire workup done within a window that's very near to the time of surgery. You know, a lot of times patients will come with a CT scan a couple years ago and this and that. Well, those investigations are not real time. I want everything done within the last 6 months because, or even 3 months would be optimal, because I want a snapshot of what's going on right now, both intraluminally and as visualized by CT scanning and other non-invasive modalities.
I think that's an excellent point. The other comment I would make in regard to the ultrasound mapping adhesions, when I operate on these patients who've had prior surgery, I try to stay away from the previous incision to get the initial access, because I think oftentimes you may have a loop of bowel that's stuck right there where you go in. You can easily get into it with an open incision just as well as laparoscopically. So stay away from where the prior incisions are. Get your access away from where the primary operative site was the previous time. So let's say you do a laparoscopy and adhesiolysis in someone like this. Do you do anything to try and prevent those adhesions from reforming? It's a little difficult to do laparoscopically, but there are adhesion barriers that you can sometimes put in patients.
Not presently, and part of the reason is because I actually think when you do adhesiolysis laparoscopically, the chance of significant adhesions thereafter is less than it would be from open surgery.
Let's talk a little bit about laparoscopy for small bowel obstruction. It's probably something that's not widely done, but you both showed how this can be utilized. Joe, if a surgeon wants to start doing this, what would be sort of the ideal case to start with to take on in somebody who's got a small bowel obstruction?
I think the ideal case is sort of, the ideal patient, not the, elderly, frail, ill patient, someone that you'd be able to take your time with. So somebody in relatively good health from a cardiovascular point of view, ASA1 for your first couple, someone with relatively short duration, preferably with only one previous operation, so you have a reasonable hope that it's only going to be one area and not an entirely plastered hostile abdomen. You need to go in away from all of the previous scars. And one thing that I find very helpful is when you first access the abdomen, and turn on the gas, if you can only get a liter or two of air in before you hit your 15 millimeters of mercury pressure, you're not going to be going anywhere. There's just not going to be enough free space, at least not where that port is located. So I tell beginners that that's a good cutoff point. You might just want to bail right there and switch to an open operation. But if you can get a couple of liters of air in, you can usually get enough working space to start adding additional ports. Add each of them at least 10 centimeters away from the previous ones and start taking down adhesions from the abdominal wall. And although sometimes it proves to be impossible, there are enough times when it is just a single adhesion and you look laparoscopically and say, well, I would have felt so stupid if I had opened. Or conversely, there's times when you open and say, rats, I should have just done it laparoscopically. So I think it's always worth a look. And we've done it with people who've had total proctocolectomies, ileostomies, esophagectomies and gastric pull-ups, pretty extensive major abdominal surgery that you can still do it through the laparoscope. Oh, and one thing people are slow to think of is using your hand on the other side of the abdominal wall to kind of push it in, change the angles, make the angles more accessible. That in a 30-degree scope. And being liberal about being willing to add more trocars, change the patient's position, move the camera from trocar to trocar, move yourself around the patient. Those are all the things that kind of lead you to success with that.
One other point about setting those up is I like to tuck the arms.
Yes.
And that way you can get up above to look down toward the pelvis much easier. If you have the arms out, then it's going to limit a little bit your freedom of movement as a surgeon and your working ports.
I'd like to comment on that. Early on, we gained some experience with, we became quite aggressive with approaching bowel obstruction laparoscopically, and I came away, and we studied our patient population with some caveats, and I agree with pretty well everything you've said, including the fact that if you can't instill a liter of gas, you're probably not going to be able to do anything in the abdomen. But what we did was we looked at all comers that came to us with bowel obstruction, and we felt, looking at various criteria, how tense the distension was, whether or not they were hypotensive or septic. I think if the patient's septic hypotensive, you probably should just do a formal laparotomy and get on with business. But when we took all comers, we found that 1/3 would not be amenable to laparoscopy and 2/3 would. And then when we approached that 2/3 group laparoscopically, we found that 2/3 we could solve laparoscopically, 1/3 we couldn't. So at the end of the day, when you look at the numbers, all comers to our practice, this was some years ago, and we had close to 80 patients. What I came away with, all comers, 50% you're going to be able to handle laparoscopically, and 50% you won't. And for that reason, I think in most instances, unless there's a contraindication, tense distension,
multiple prior
hypotensions,
operations,
etc., you probably should proceed with laparoscopy.
The other point I would make is you want to have a set of really atraumatic grasping instruments, and you've got to be very gentle handling the edematous bowel, because it's easy to get an enterotomy if you're too aggressive.
And you have to see everything that you touched. It's alarmingly easy to make a little tear sort of as you move your hand out of the field. I think you made that point during your talk. I think it's important to see when you grab it and when you let go of it as well.
Right, and one other caveat is always start running the bowel from the non-distended bowel. Run it toward the distended bowel. Because what often happens is you're actually grasping, relatively normal bowel, and you're actually following it up to the obstruction point, which you then relieve. And in fact, without really handling or doing much handling of the obstructed bowel, you've actually solved the problem.
Good
That
point.
makes sense.
Yep, good point. Let's touch again a little bit on laparoscopic versus open appendectomy. One of the issues that I think limits surgeons from doing more laparoscopic cases is the problem doing a laparoscopic procedure after hours, set up equipment, waiting for things, etc. Joe, Demetrius, you had any success in improving that problem in your institutions?
I think it's an advantage if you have a minimally invasive room, with the video towers up on booms, so people aren't having to hunt down video towers and bring them into the room. It's an advantage if you have pre-packed sets, defined disposable instruments, identified trays for the equipment that you want to use, and it's a legitimate and real problem. Most of the studies report operating times But you and I have talked about this before, that the operating time isn't really the issue. Once you start the case, it will usually move along okay. But there's often a very long delay in getting everything together. There's often a very long delay from the time you put the patient to sleep to the time you actually start the operation, while you bring equipment in, while you look for things that are missing. So I think it's just, if it's something that you're committed to, then it's just annoying persistence, that the nurses need to be cross-trained, that the equipment needs to be clearly labeled and set aside, that the video towers need to be maintained.
Talked a little bit about some of the advantages of laparoscopic versus open. There should be fewer wound infections if you handle the appendix properly, because it should never really touch the wound. And you showed putting it in a bag, which anytime you have a very distended appendix, you should do that so that you don't drag it through the wound and particularly don't rupture it as you're pulling it out through the wound. And there was a little bit of advantage of length of stay, but in my experience, the primary determinant of how long the patient's in the hospital is how severe the appendicitis was, how much inflammation they have, how much associated ileus, et cetera, et cetera. Any comments on that, length of stay?
Yeah, I think that's true. I think that clearly a patient with perforated appendicitis will stay longer than one with non-perforated appendicitis. But I would say, and I think most of the data would substantiate that, if you match the patients, which means like if you do a randomized trial, if the series is large enough and randomization is proper, then you're likely going to have similar groups. So whether it's perforated or non-perforated, the perforated patients done open and laparoscopic, there'll probably be an advantage for laparoscopy, and the non-perforated, there'll probably be an advantage. But if you were to compare perforated with non-perforated, of course, it would be the disease process that would in fact be the arbiter as to how long that patient would stay. I'm
really not convinced that laparoscopic appendectomy patients do better early on. It's really not, it's not clear in the literature, it's not clear in my practice. Some of them do extremely well, some of the open ones do extremely well. And I think that the advantages of doing it laparoscopically have more to do with your ability to see during the procedure, to maybe make smaller incisions in obese patients to help clarify the diagnosis in women. But I remain unconvinced, actually, even though I do it laparoscopically almost all the time, that the laparoscopic cases will get out faster or do better.
In most cases, there's probably not a huge difference in terms of length of stay, recovery, complications, et cetera.
Right. Even a lot of the studies that report that there was a statistically significant difference, they're talking about a difference between a 23-hour stay and a 29-hour stay, or something that might be statistically significant but is not actually clinically significant.
But you mentioned some subgroups, women, because of the diagnostic considerations, obese patients, athletes, laborers. Is there a difference in terms of return to unrestricted activity, either hard physical labor or athletics?
And the first two categories, certainly, women and obese. I don't know about athletes and laborers. It's not been my experience that there's much difference, but I don't know about formal studies. Do you?
No, not other than what, the randomized trials. And once again, it's a grab bag in terms of the outcomes, in part because I think of what we've said, when there's not a great difference, you've really got to have big numbers to show a difference. And many of these trials they're well constructed, but the numbers are actually small, and you need fair numbers to show a 4-hour difference or 8-hour difference or whatever it is. And so whatever that difference is, I agree, it's not a huge difference, but and often you select the studies that support your point of view, but I personally think there's an advantage in all of those groups to the laparoscopic approach.
We selected several of the same studies to support our opposing point of view, which is like another legitimate point. I also think that with athletes and laborers, they tend to be fit. They're fit and they're thin, and so they do, you can do it through the little incision and get things forward pretty quickly.
Well, the athletes aren't always thin. They may actually be fairly muscular, and that's the one group, in my experience, I'm convinced that there's a benefit in terms of getting them back to athletic competition.
The concerns I have is, with respect, another concern I have that we haven't talked about to a large extent is misplacing the appendectomy incision. I mean, if you're going to do it, for example, even if I were to say that, well, there's really no difference, I guess that's true if your incision is in exactly the right spot over the appendix, but suppose it's a high appendix, you're going to have to enlarge that incision, and I do think the laparoscopic approach will have a benefit over the patient that now has had an extended incision to get out the appendix.
Or retrosacral appendix.
Correct.
Same issue.
That's one
Right.
scenario. The second thing is, and it always disturbed me when I used to practice open appendectomy, you know, you make your incision, you're looking through a small hole, you pull out what we used to call a lily white appendix, and you take it out, and now you look for a Meckel's, you don't find it, you don't see turbid fluid or anything that looks, or you might find some turbid fluid, and then you'd convert, and you might convert and find nothing, and now the patient has a laparotomy. Or if you found nothing, you basically took a patient who you took to the operating room for a septic process, white count, etc. You found nothing, and now you're going to close up that incision and continue to watch
He
it.
said it's okay, right?
Yeah, with a laparoscope, at least you can look around.
Sure. Let's talk a little bit about technique. You showed some nice video clips and showed your choice of port placements. There's a variety of different port sites that people can use. One of the things I've found useful is to make a small supraumbilical incision for my initial access. It gets you a little bit further away from the appendix and gets you back from it a little bit so you have a little better view. And then I triangulate from the left lower abdomen and the suprapubic area. So that's one other port site placement that you can choose to do that. The use of the stapler, I think, makes sense. And do you always try to isolate the appendix at the base first, or sometimes you'll go across the mesoappendix first and before you get to
Yeah,
it?
whatever makes sense when I'm looking at it with my ports in whatever position I have, my standard position I showed earlier. Whatever seems to make sense, that's how I approach it. If it makes sense to transect and then I get a better shot at the mesentery with, let's say, the stapler with whatever instrument I'm using, whether it be bipolar, then I'll do that first. If the orientation is great, then I'll take the mesoappendix and then I'll deal with the base last. So it really doesn't matter. I think what's key, though, is to make certain that you are at the base of the appendix.
Yes. There have been cases of partial appendectomies and patients coming back with recurrent pain. So that's a key point. You have to be sure that you're all the way down at the base on the cecum where you put your stapler, right? Do you usually take the appendiceal artery with the base, or do you?
No, I like to take the.
You like to have just the appendix isolated.
Correct.
And not any mesentery in it when you divide it across the base
Right.
of the cecum, right?
That's correct. I don't, especially with the stapler technique, because you're really dealing with separate structures and separate tissue consistencies, and I hate to take one stapler for both structures. So I take the mesoappendix with whatever it is I think I need to. I inspect it. Occasionally you'll see a little bit of bleeding through it. You can simply grasp it and give it a little buzz with electrocautery. And then I like these cecal base isolated. I think I get a better view of the base. I think I know for sure I'm at the base, and I transect the base.
Joe, any comments about laparoscopic or open
No,
technique?
I mean, I agree with that and doing them separately. And there is a sort of trend towards more bleeding, more minor bleeding complications with the laparoscopic approach. So I think you have to be careful that you get the whole thing. So no, I don't have anything to add to that.
The other point is, if you have to be careful about mixing clips and the stapler, because if you put a clip or two on the mesoappendix and then you try to fire the stapler, you can have a stapler misfire.
Right. We should talk about the different size staplers and which is appropriate to use, I think. You mentioned that you like to use smaller staplers than you normally use on bowel. You said a gray or a red load for the appendix?
I use the white load, the 2.5, typically for the base of the appendix. And actually, if I do a small bowel resection now, I'm more likely to use the white load than the blue load.
Is that right?
Yes.
Well, it's consistent anyway.
Just because I think it's thinner than we heretofore believe, that just based on my experience.
Unless you have a thick and you got edema in the base,
Yes. Then you
the
upsize,
appendix, then you go
obviously.
to a blue load.
Yep.
Well, let's talk about some cases now. We'll see how you manage those. The first case is a 47-year-old male who presents with 3 days of worsening right lower abdominal pain. And on exam, he's tender in the right lower quadrant, he's got guarding, he has a white count of 16,000, and as do most patients today, he gets a CT scan before the surgeon's called, and he's got marked enlargement of the appendix, and he's got extensive mesenteric stranding, and he's got some cecal diverticuli, but it doesn't really look like diverticulitis. So you can see here on the scan this sort of inflammatory mass and dilated appendix. Joe, how would you approach this patient?
That looks sort of intimidating laparoscopically. There's a fair amount of inflammation, although I really have a let's look and see policy. So I would put him on antibiotics and resuscitate him and take him to the operating room and start off by looking with the laparoscope, see if we can get things mobilized. He looks like someone who could conceivably need an ileocecectomy, which can certainly be done through the scope, but I almost never start with an open procedure, and it doesn't look like he's someone that you should try to temporize with antibiotics either.
Demetrius?
Yeah, I'd start with the laparoscope. I think
so. This wouldn't be a contraindication in your mind for putting the scope in, having a look. And
No.
No, and you're going to end up with three options whether you do this laparoscopically or open. You're either going to find that it's a real bad appendicitis, but the base of the cecum is relatively spared, or spared enough so that you can staple across it or ligate in some other fashion. The stapler, I think, is particularly suited to this type of case. The second possibility is that the cecal pole is actually involved, but you can amputate the cecal pole, and you can do that. I've done that laparoscopically a couple different ways. I've simply incised it and hand sewn it, and now I staple it. That would have been in the early years, I would have done it that other way, and now I would just staple it. The third option is that you've actually got to do an ileocecectomy, which can be done open or laparoscopically, and I would attempt to do that laparoscopically and handle the whole thing with a laparoscopic approach.
Let's say that you get in there and you're able to resect the appendix and you staple across the cecum, but it's fairly edematous and you're a little concerned about that staple line. Do you ever oversew that or reinforce it in any manner?
I think you certainly can oversew it, and I think if you're going to approach these cases that way, you should have the skills to be able to do that. You know, if you need to have advanced laparoscopy skills to tackle one like that. You should be able to sew, you should be able to manage a 30-degree scope, all those issues. On the other hand, it might be the better part of valor if the cecum's edematous and you're asking it to hold a staple or a suture line to move farther up, farther proximally and farther distally, and take more healthy tissue.
Yeah, I think you can oversew the staple line. What I don't do is invert the staple line, because with those stitches that actually invert the staple line, if you think there's tension transecting it, then trying to actually stuff that and invert it, it really looks to me like, well, the tissue's too friable. My fear then is that the stitches will just pull through this friable tissue, and now you're in a worse situation than you were before. The other thing you can do is you can take you can create a small amental patch, doing it much like a Graham patch, where you put a couple of serosal stitches, lay it over on each side of that staple line, and just tie it down over top that staple line. So there are multiple strategies, open or laparoscopic.
Let's say at operation you find a retrocecal appendix. You showed part of that in a video clip. Any other tricks for managing a high retrocecal appendix that goes almost up to the edge of the liver? Sometimes you'll encounter one of those that is a really high retrocecal appendix.
I think some of the tips that Demetrius talked about, particularly trocar location, that for a high retrocecal appendix, you'd like one of your trocars in the right upper quadrant instead of all across the abdomen. And also positioning the patient with gravity on your side, really rolling them up so their right hip is up and their head is down and their left side is down to expose everything. And then some patience and some blunt dissection will probably get you where you're going.
I agree. I think worst case scenario in any case of appendicitis, you've got to mobilize the right colon, and you have to be able to do that. Otherwise, there will be a subgroup of patients that you'll have to convert.
And usually the radiologist will tell you if it's a retrocecal, I mean, you can see if it's a retrocecal appendix on the pre-op CT scan if you have a CT scan. So that can also give you a clue in advance that you're going to have to deal with that and prepare accordingly. So let's say that you get in there and you find Crohn's disease of the terminal ileum. How would you deal with that?
Well, typically, if the base of the cecum is not involved, I'd still take out the appendix. Beyond that, I think typically that patient will then be managed medically thereafter, and I would not do a resection at that point.
So let's say that you've taken the appendix out, and 3 days later you get the pathology report back, and there was a 2-centimeter carcinoid tumor in the appendix. What do you do?
So depending on what kind of information you had ahead of time, you'd want a CAT scan to look and see if there's any other disease, and then you need to go back and do a wider resection, which can certainly also be done laparoscopically.
Which would be a right hemicolectomy?
A right hemicolectomy. on the other hand, if the pathology report came back with a really small sub-centimeter or 1 centimeter or smaller tumor, then I think the appendectomy would be sufficient.
So let's go to another case. This is a 42-year-old male who's had recurrent discrete episodes of nausea, vomiting, and abdominal pain. These episodes last about 30 minutes in duration, and he's otherwise fine in the interval. He does have a history of a prior exploratory laparotomy and small bowel resection for appendicitis at age 10, and he's had a recent extensive workup, upper and lower endoscopy, upper GI small bowel series, CT scan, and because these episodes are short-lived, they haven't been able to do any of these right when he was symptomatic, but the workup has been negative. What do you do next?
I've seen patients much like this that give a history that's suggestive of recurrent bouts of bowel obstruction with nausea, vomiting, and often they'll complain that they're distended and so on and so forth. And one of the first things I do, because these patients often have gone to the emergency room, is I look for the investigations that were actually carried out when they went to the emergency room. Even though they will report sometimes that nothing was found, because they got better, they were sent home from the emergency room and there was no follow-up at that time. If you review those films later, you'll actually find dilated small bowel. I think if you have a hard finding with that history of dilated small bowel at the time of an appearance in the emergency room, then I think you can justify going forward and doing an exploratory laparoscopy. Similarly, if at one of those times a CT scan with oral contrast was obtained and you actually find that there's some dilatation at that time, then I think you have some hard evidence. In the absence of hard evidence, with a 30-minute history, I'd be very reluctant to proceed with an exploratory laparoscopy on that visit. And what I typically tell patients is the next time I give them my office number and so on, and I say, and I give them the number to call if this happens after hours. The next time this happens, come immediately to the emergency room and my team will see you and we will image your abdomen. And at that time I'll image the abdomen 2 ways, abdominal films and a CAT scan. The abdominal films can be done immediately, the CAT scan with oral contrast, and you look for telltale signs that suggest that in fact there is an obstructive process. And I would want something hard, some hard evidence before I proceeded.
So they come in after they have this event. I just had this guy, in fact, he came in, I saw him last June, he came back in on Saturday, clearly obstructed, and went home on Sunday when it relieved itself. So he has these 30-minute episodes, is lysing his adhesions, these 30-minute self-limited episodes. So even if you prove that during one of those episodes he was obstructed, was that someone that you would still operate on?
Yes, because the 30-minute episode is not always, or might not always be the 30-minute episode. I mean, presumably, and we see this, we see patients who come in with bad obstruction that said, you know, I was getting problems. They weren't sure what was going on because they were self-limited episodes, and then they come in with really a bad obstruction that doesn't, that is not treatable by conservative measures, and we end up having to operate. So I would operate. So
the guy I sent home on Sunday is coming back for surgery in a couple of weeks.
So this patient actually did get an exploratory laparoscopy and was found to have a single band between the omentum and the cecum, partially constricting the small bowel loop, but not completely obstructing him. And so that was presumably the basis for his episodes. This was lysed laparoscopically. He had no more episodes subsequent to this. So I think this illustrates how it can be a useful application in this setting, but as you say, you try to catch these patients when they're symptomatic and get imaging, and then you can certainly feel a lot more confident proceeding with an operation then.
What if you weren't so lucky? What if when he came into the emergency room it still didn't show anything, or he never made it to the emergency room, or the episodes only, you know, by the time the emergency room doctor saw him 6 hours after he arrived, he was better?
Right. I think then you really have to make an assessment as to how good the history is and how credible the person is in terms of that, and then make a judgment call. And I think sometimes you probably will make the correct judgment, and other times you might not.
Next case is a 43-year-old male with a history of peptic ulcer disease. And this patient presents with acute abdominal pain. On exam, he has abdominal rigidity and tenderness, and a CT scan shows free air with some fluid. So he's got a presumed perforated viscus. Joe, what would you do?
A 43-year-old healthy guy, or presumably healthy guy, and that's a very good candidate for what we talked about during the presentations, which is a laparoscopy and presumably repair of a perforated ulcer. It's a pretty straightforward, short procedure. You know, single stitch. Anyone who certainly, if you can do a Nissen, you can do that. I think the issue is how well can you wash them out? Can you get fluid down, you know, into the pouch of Douglas and you know, all the other cracks and crevices? And if you attend to that, changing positioning, using copious irrigation. It takes longer when you do it through the scope than it does open. You can't just dump a bucket in. But as long as you wash them out appropriately, I think that's the right way to do it.
Can you just say briefly how you close this? Do you use an omental patch and sew the omentum into the defect?
Yes, we use a standard gram patch where you place a couple of stitches, probably 3 would be pretty typical. Using a non-absorbable suture to the side of the hole, through the hole, out the other side. And bringing in a tongue of omentum to sit across the hole to buttress it.
Sometimes if it's unclear what the source is, you put a scope in it, even if you end up opening, you've better planned your open incision.
Right, and opening is should be it shouldn't be something to be resisted under these circumstances. It's an entirely viable fallback, and yes, you might have gathered some useful information off the bat. You know, if it's just plain free air and you're not sure what it is, you know, it could be the difference between an upper midline incision and a lower midline incision.
Right. Let's suppose that you get in there with a scope and it's a perforated diverticulitis. What do you do from there?
I would have a higher threshold to convert to open surgery with a perforated diverticulitis, especially if there's fecal soilage, because I'd be a little less confident that I could get that really thoroughly cleaned out. Not so much that you can't do you can either drain it or do a resection, but that you'd be more prone to postoperative abscesses. So if you have mobile sigmoid colon, you have a couple of options. You can do a resection. You can do a drainage and start antibiotics and come back later. You could do a colostomy in Hartmann's pouch, although probably that's pretty challenging through the scope. I'm not sure that I would approach that through the scope unless it was very simple and straightforward. How about you?
Well, you know, we would look in. I think if there's solid feces, you've got to get that out, and it's real hard to get that out with the scope. But usually that's not the case, and I think how you handle the colon will be directly related to how inflamed the colon is, how big the mass is, the inflammatory mass, how thickened the mesentery is. I personally would attempt many of these laparoscopically, recognizing that I will fail sometimes to do this laparoscopically. I think there are some caveats. I think you have to have a high level of expertise in terms of colon surgery. This is not for the occasional colon surgeon. You have to be very confident in your abilities. You have to be able to demonstrate the ureter because, you know, this is a situation where you can cause a great deal of trouble in terms of injury to the patient. And the other thing is, because of this thickened mesentery, one of the mistakes that I think is most common to make is the resection is relatively okay, but not enough length of mesentery is obtained in order to bring the colostomy up without tension, and you end up with a black retracting colostomy postoperatively, necessitating a second operation. I mean, this is a real problem in open surgery, and I think it's compounded because of the inability to judge, the inability to determine how far you really need to mobilize, the inability to really, with laparoscopic instruments, understand how much tension you're creating, and the inability, once you've done that and made your incision, to bring out the stoma, to actually go back. In open surgery, you can work, you know, through the stoma hole, through your open incision, and so on. So those are the caveats. But I think it's doable. It's certainly doable in experienced hands. But there are a number of occasions when it should not be done, even in experienced hands, because of the scenario that one encounters.
Next case is a 68-year-old woman with a suspicious lung nodule. She's scheduled for a biopsy. And prior to that, presents to the emergency room with acute abdominal pain, a firm, tender abdomen. She gets a CT scan, shows no free air or inflammatory changes. Joe, is there a role for diagnostic laparoscopy in a patient like that? You're really concerned that she's got an acute abdomen, but you don't see the nature of the problem on the CT?
Oh, I think that, you know, that would be one of the indications for laparoscopy. Somebody who's really apparently sick with no cause. You know, the old days we would have done peritoneal lavage, but laparoscopy will give you a lot more information. So yeah, she is, you know, assuming that she's stable, she's definitely someone to take to the operating room and use an open approach, an umbilical incision, and look.
So you do that in a laparoscopy, you find peritoneal carcinomatosis. Other than biopsy, anything else to do?
You could certainly take a look all around the abdomen. You know, in a 68-year woman, you'd be worried about her ovaries, so hopefully you put her in a split leg position and are able to examine her adnexa, tip her down, and run the small bowel. You know, look for primary source as much as possible. It would be important to get frozen sections during that procedure because you know you've got something, and it's easy with the little biopsy forceps to get a little bit of peritoneum and not actually get what you're after. So you need to make sure you've got diagnostic tissue before you leave the operating room for her.
Our last case is an 88-year-old man who's in the ICU. He's in there with atrial fibrillation, some congestive heart failure, and he develops abdominal pain and lactic acidosis. He's mildly distended, he's somewhat tender, no peritoneal signs, bowel sounds are somewhat hypoactive, his white count's just slightly elevated, and he does have a lactic acidosis, so that's why you're called. He's had a CT scan, and it really doesn't show very much. Demetrius, how would you approach this patient? You've been called as a surgeon to evaluate this individual.
Remember, there are other ways you can look at viability. You can do a gastroscopy and a flexible endoscopy from below, either flexible sigmoidoscopy or colonoscopy. So depending on what the scenario is, you might actually consider doing those before you consider entering the abdominal cavity with diagnostic laparoscopy. The question then is this patient a candidate for diagnostic laparoscopy? And despite the fact that he has congestive heart failure, I would consider that. Then the question is, where's the best place for diagnostic laparoscopy? Because ultimately, if the diagnostic laparoscopy is positive, you'd like to proceed at that very moment with a therapeutic maneuver. So if the index of suspicion is very high, and if the patient is stable enough to be transported, I would actually do my diagnostic laparoscopy, not at the bedside, but in the operating room, because then I can follow through either with a laparoscopic or an open approach at that moment. I think the scenario in the ICU occurs when you've got a patient that's very labile. You can't transport the patient. You know, they're very ventilator dependent. And when you take them off and you try and bag them, you can't get very far. You've got to get them to some, you've got to get them either to the CT or you've got to get them to the operating room. You've got to get them someplace in order to do the diagnostic maneuver. In those cases, you would not like to transport the patient and or give them a major intervention if indeed there's nothing going on and the source of sepsis is lung or something else. I think those are the cases where you would consider in the intensive care unit doing a diagnostic laparoscopy or a bedside laparoscopy, and that's been our philosophy with respect to that.
You've done this a few times. Do you just bring your equipment up from the operating room and have your personnel there, an anesthesiologist, and the whole team is there, and you've got your equipment? You're just doing it at the bedside.
Right. We even are ready to convert if we have to. Okay, so we can actually do the operation. We can do an operation there, even though it's, but you never know what you're going to encounter. And certainly if we put in the scope and we accidentally injure a structure, we might need to convert. Remember, these are patients that are on the edge, and they won't tolerate much. So we actually felt that we needed to be prepared to actually formally convert. So we actually have the OR nurses up there. We're ready, if we need to be, to set up and actually do a formal operation, although we never had to do that.
I think laparoscopy in the ICU is actually less prohibitive than open surgery in the ICU, which is even more rare. But you know, the open surgery in the ICU is limited by lighting, at least in my experience. In laparoscopy, you can actually see about as well. What do you think about being able to tell sort of grades of ischemia, blueness, duskiness, being sure in someone like that?
Well, you know, what you're talking about is how well does a laparoscope render color? And obviously, if you can find peristalsis, it's probably viable, but color rendition or color rendering is real important. It depends on the tint of the monitor. Mm-hmm. Cameras are different. If you go to a video store, you'll see a bunch of TVs, and gosh, the colors look different in all of them. And so that's a real important point. Oftentimes, though, it's either clearly viable or it's clearly not viable. In those in-between areas, I really think you've probably got to proceed to laparotomy. And even then, it can be very difficult to decide whether or not the bowel is viable or not viable, quite frankly. Flip side to that is, let's say it looks like you're not sure, it all looks like it's questionable, but it's questionable from stomach to rectum.
Low flow state.
Low flow state or whatever. Well, you're not going to convert that patient. Even if it's questionable, you know that what you have to do is improve hemodynamics. The solution is not a laparotomy.
I'd like to thank Dr. Beiske and Dr. Litwin for being with us for this program and for their excellent presentations. And we'll look forward to having you with us for the next issue on laparoscopic management of tumors of the colon and stomach.